Now we've got the pleasure of introducing Mr. Francois Renaud, who is a consultant general and colorectal surgeon in University Hospitals Leicester, and he's going to talk to us a little about. Leading on from the surgical challenges, we're now going to talk about the surgical challenges in gynecological surgery. Thank you.
Good afternoon, everyone. Thank you for having me, and thank you for the panel and committee for inviting me. Let me try this. So my name is Mr. Renaud, one of the colorectal consultant surgeons at UHL, or University Hospitals Leicester. It's in front of me. So my first disclosure is with, I do have some industry support from a laser company, but it's not relevant to this. Otherwise, the main caveat is I am not the gynecologist. I'm a colorectal surgeon, but I do give a lot of support to the gynecology unit. Particularly, I'm one of the named surgeons for the we are a BSG endometriosis center. I also give a lot of support to the gyne-oncology team. My second caveat is that I have a 4-week-old baby, so I might not have, if my performance is not up to scratch, then please be kind. So I thought about what to talk about, and I thought I'll try and do some acute problems and then some evolving or elective problems, and then try and add on from that. Being on call in general surgery, we see a lot. I don't really see this, but we see a lot of patients that come in with obviously abdominal pain, sepsis. You get a scan. Now, luckily, I think this applies to most centers. We do have very good radiologists. If the radiologist is very clear and says it's a tubular ovarian abscess, then usually that's something that obviously gets treated by yourself or your colleagues. The real questions are when you have problems associated with the bowel. For example, how can you tell the difference between a tubular ovarian abscess and an appendix, or diverticulitis? Again, if you have very good radiologists, they will be able to give you the answer, but really the question is, what do we do? Again, so we looked into what the evidence says, and in America at least you can have about 200,000 patients present with PID, and if they do rupture or become a tubular ovarian abscess, you can get up to about 4% mortality. Now the treatment, it's usually a chicken and egg question. If you have an abscess, then you have some stranding in the sigmoid colon, or there's some thickening in the appendix. What do we do? And that's a lot of. Those are a lot of the questions that we get, or I get, when say like a normal on call. And the treatment's usually the same, which probably applies to you. It definitely applies to everyone here. Your basic resuscitation, antibiotics, imaging. Our first treatment, if possible, would be to try and see if it's radiologically drainable. The next option would be to see if it's laparoscopically drainable. But as mentioned, what do we do about the ones that involve the bowel? Now, I looked specifically into to see if what the incidence of concurrent patients having a tubular ovarian abscess as well as diverticulitis, and there actually isn't a lot to find. It's not, and I'm not sure, is it because it's something that happens so often that it doesn't get reported, or it doesn't get a response to? But what I do know is when it does happen, when you do have a very big, complex pelvic abscess and you don't know where it is, I think the key is to make sure you get the right specialty and the right group of people to come in. A multidisciplinary approach. A lot of times, if you're doing surgery, you need to get good radiological planning. If you see what sort of access, what sort of like structures are involved. Because it's often very messy, and it does carry quite a lot of comorbidities. And I know we've talked about, we just listened to talk about ovarian cancers. But the main, so this is a CT from a patient, and again, this is another common issue that we see, mechanical bowel obstruction. So this is a case of a young woman who has had interval debulking surgery or interval cytoreductive surgery, but has got recurrent disease. And more often than not, they actually come under the general surgeons. And to be fair, I think that's a common avenue. If someone has bowel obstruction, they come to A&E. It's not very often, or more often than not, that they come under the general surgeons. In some ways, in Leicester at least, we do have a specialty take where we do have colorectal as well as upper GI. So most of the acute bowel obstructions come under colorectal. But even then, what do? You have a patient who's been labeled as recurrent cancers with multiple transition points, with multiple serosal disease. More often than not, they get written off. Bowel obstruction in general is very, very common, something that I see all the time, obviously. The two most common causes are adhesions and hernias, and only 2% of it are actually due to malignant bowel obstruction. But if you look at it deeper, if you dive deeper into it, in ovarian cancer, the incidence of having bowel obstruction actually goes up to more than about half of them, 51%. But if you again look specifically at malignant small bowel obstruction, you'd be surprised to know that actually 56% of malignant small bowel obstruction is due to an ovarian cancer or gynecological cancer. And that's followed by colorectal, which is only 20%. So if you think about it, I'm now treating a patient or a woman with bowel obstruction, which I know what to do, but I don't really know what the primary outcome is. As in, I don't know, that's not quite true, but a lot of my colleagues will not know what ovarian cancer or gynecological cancer, what the prognosis is, what the outcome is, and honestly, they get written off quite a lot, which is a bit, obviously not very fair. So there's been some work looking at this. I think it's from the Manchester or the Christie group, looking into what the outcomes are for patients with ovarian cancer with malignant small bowel obstruction, and the best outcome is having some form of chemotherapy, followed by surgery, and followed by not doing anything, which is probably the worst one. But I think that's, again, something that's very tricky to try and change. I can tell you from a lot of experience, particularly from being a trainee and being a consultant. The moment, if in a unit where like the general surgical take is done by an upper GI surgeon, the moment you label, I've got someone with a recurrent ovarian cancer with multi-level bowel obstruction, the answer would be NG tube and palliation. But this is probably where something that we could do better with. So in my unit, or particularly with me, because I have good contacts with the gynaecologist, I dropped them a text, I called them directly. Obviously we do all the basics, which is obviously that's something that I do, but, keeping them nail by mouth, put an NG tube in, catheter, et cetera, it's pretty basic. But then having an early discussion with the gynaecologist and finding out what their prognosis is. And then more often than not, we do, again, have an acute oncology service. So we call them, they come in, they assess them. And it does show that there is, you can see the evidence there that there is an improvement with having chemotherapy. I suppose the real question, though, is at the end of the day, it's all about we are treating a disease that has a very poor prognosis, and it is about making sure we explain to patients, be realistic about what it is that we want to achieve. It's mainly about quality of life, but having a good team to talk about what to do. I frequently, when we see patients like this, we give them some steroids, and it does help. And again, it's pretty small there, but the blue one at the bottom shows that there's a 90% chance that they do get improvement, but the general story is that they get better. So a patient comes in, they get the steroids, they get the NG tube, the bowel starts working again, they go home, they come back 2 weeks later, again, usually the same, maybe not under me, but usually under a general surgeon. You do the same thing and again before they, unfortunately, die. Again, in my unit, we're quite good with giving TPN, or rather, we have good access for TPN. But the moment you say someone's got a recurrent cancer, the intestinal failure, the intestinal failure team will be very hesitant to give TPN because they want to know what the endpoint is. But that's something that can be done. Use gastrografin a lot. I'm not sure if that's something that that's used in your practice, but it's very, very. I think it's been used up by so many people because there's recently been a shortage of gastrografin. And stent. Now, we don't tend to do stents very much because colonic stents are usually for colonic obstruction, but most of this obstruction is actually due to small bowel. So we can move on to some more elective cases. So again, because of my good relationship with the gynae oncology team, they send me a lot of patients. I tend to not say no, I tend to say yes, which is maybe detrimental at some point. But I see lots of patients with hernias, essentially. The first one on the right, a woman with endometrial cancer, but it's got this huge, large, pendulous umbilical hernia. More often than not, I get an email or get a request saying, like, why don't we do this together? And it's reasonable to a midline. The second one on your left, on my left, is another patient with endometrial cancer, but she's got peritoneal deposits, which is going into her hernia. I needed an MDT to say, I don't think this is a good idea. And luckily everyone else, because the patient wanted me to do something, but luckily everyone else agreed not to. The other side of this is postoperatively. So again, this is a patient that's had, staging laparotomy and pelvic clearance. But you can see this is the same woman, same scan, but she's got multiple hernias. And the question for me was, can you fix it? Now, I can fix hernias. I'm an abdominal wall reconstruction surgeon. But it's a very big surgery, 6 hours, do component separation, make sure I don't injure the bowel. There'll be a lot of adhesions, but it's doable. But my real question is, will it come back? And I think we've heard from a colleague previously, recent, that it does come back. So it's a difficult conversation that I tend to have. I said, well, I could fix it. I could do all that work. You could have a mesh, but if you have a recurrence, what we're going to do about it? And again, it's all down to having that right discussion and talking to patients and finding out what to do next. So this might be something, it's not new, but I'm not sure how much this has gone down to other specialties. So about 15 years ago, there was a Swedish group that essentially, one of the biggest bugbears for general surgeons in general is having a big hernia after laparotomy. There was a group of Scandinavian surgeons that identified by doing small bites, using for example, a 2O PDS. Small bites meaning, so the traditional way to do a midline closure, as I'm sure you know, is to do loop PDS, do mass closure. But we found out that the incidence of having an incisional hernia is 21% versus 13% if you do small bite closure. If you if we do a show of hands, everyone in the room, if we were to do a midline closure, who does a mass closure? Has anyone heard of a small bite closure? Okay. I take it, okay. Because that's probably something that's changed in the last 10 years. that almost most, if not all, colorectal and general surgeons will do small bowel closures now, based on the top right evidence. From a post-operative point of view, if anyone sees a burst abdomen on the ward, that's a very simple. You have to go back in. Sometimes, you might need to call a general surgeon in at that point, but then we think about the type of incision that we do. So if you do a midline incision, the chances of having a hernia is 15%, whereas if you do a finastial, which is obviously a bit more of your bread and butter compared to me, you can reduce your incision hernia rate by almost 12 times. So knowing that, so now, obviously we do robotic surgery, we do laparoscopic surgery, but a lot of the extraction sites for colorectal surgery, we now do finastial incisions. So, I would think that we are sort of like learning from each other. Obviously, the other advantage of doing a finastial incision is the pain profile is lower because you cut through a single dermatome much further down. But clearly that, doing a finastial incision isn't always going to work. So this is a patient that has a very, very, very big, this is an MRI scan of a patient that has a very, very, very big lesion. It was identified to have come from the uterus. And I got involved because, again, as the abdominal wall reconstruction surgeon, I'd be like, how do I take this out? My answer was definitely don't do a finastial. But, we're there. So you can see that it's a huge mass. I think it was like 30 kilograms. She lost a lot of weight very quickly in 6 hours. Right. So this moves on to bowel resection. Now, again, based on conversations, mainly informal with a lot of gynae oncologists, bowel resection seems to come up a lot, okay? Particularly in gynae oncology surgeons. And again, we saw a good slide about the TRUST study that showed that, the big things, taking a spleen out, taking bowel out, is relatively common, but does carry some morbidity. So if you look up the evidence of anastomotic leakage for bowel resection in ovarian cancer, just generally looking anastomotic leak and ovarian cancer, there's a lot of papers. There's a lot of interest in this. And one of the reviews suggests that the incidence is about 5%. And again, I'm a colorectal surgeon, obviously, and I know that, not mine, but the leak rate can go up to 20%. But the question really is, what is the leak? I mean, I know you know what a leak is, but not all leaks are the same, because you can have different types of, there are different grades of leaks. But some leaks you identify on the scan, but you don't do anything. Some leaks you just defunction. But some leaks you have to take the anastomosis down, which means a reoperation, etc., etc. But the other thing to say is the disease is different. If you think about ovarian cancers, they're peritoneal. It's a peritoneal type disease. So you have cancer on the lining. What that means is that when I do a bowel cancer resection, I have to do a high ligation. So I take the blood supply at high the IMA close to the aorta, or if I do a right hemi, very close to the ileocolic artery pedicle. But what that means is that because if you only have to take a wedge that's close to the mesentery, your blood supply will be good, because the leak rate, as much as whatever we want to say, but the reason leaks happen is going to be due to poor blood supply. So I would say that the disease process is different. So, and then we looked at, again, there was a group in Hammersmith, I think, that looked at whether doing a stoma in ovarian and bowel cancer, in patients with ovarian cancer who had a bowel resection made a difference. And 20% patient had a loop ileostomy. And again, it'd be very it wouldn't actually be very easy to identify in colorectal surgery what the rate of loop ileostomies is, because it's so varied and there's no sort of guidelines. But I can understand that like there's a lot of nervousness about people about if a gynae-oncology were to have an anastomotic leak, that it can be a lot of questions can be raised. The other thing to mention right at the bottom is that the different ways, I mean, again, this is mainly in endometriosis surgery, but doing, there are some papers that look at resection versus discoid excision versus shaving, and obviously having a resection carried a bigger leak compared to doing shaving, which then leads to a fistula formation. So again, if you have a leak, if it's a catastrophic leak, there's almost no question. You have to go back in and treat it. But a lot of leaks, and I do have a case to go through, but a lot of leaks can then almost lead into a fistula. Now, a fistula, as you know, is an abnormal connection between two epithelial surfaces. The general training on how to treat fistulas is what we call the SNAP protocol. Again, I'm pretty sure you would be aware of this, but sepsis, nutrition, anatomy, and procedure. But the most important bit is sepsis. If the sepsis is under control, everything else you can do and deal with. But if the sepsis is not under control, then there's almost no argument. There's no get-out clause that you have to go back and go down the route of surgery. So when I think about my bowel resections, I think about it from the moment I see the patient in clinic. So think about them preoperatively, counsel them, etc., etc. As we said, no one really wants to have a stoma, but we assess them. So we tend to do CPET tests, and I understand that in gynae-oncology, CPET test is not widely used. Or adhered. It's I do understand that they have ascites, they have pleural effusion, so the correlation between CPET and outcome is made in gynae-oncology surgery is not always applicable, but I definitely use it. I use it for things like counseling. If someone has a poor anaerobic threshold, and I know that if they were to have a leak, they would not make it out of hospital, I tend to say to them outright, what do you think about stoma? And most of them actually understand. We talk about mechanical bowel prep. Again, both my endometriosis surgical colleagues as well, gynaecology colleagues are very good at giving mechanical bowel prep, but now there's a move to give them oral antibiotics as well, based on the MOAB study, and also prehab to try and improve their outcome. Intraoperatively, again, so standard things like minimally invasive surgery at a lap or robotic, fluid management, goal-directed therapy, giving antibiotics and induction. But again, when we do the anastomosis, we have things like ICG. We do leak tests, either with a blue hypotopic needle, or the jacuzzi test is where you put fluid in the pelvis and then you put to test the anastomosis, you blow it up, put a rigid sig in to blow it up and to see if there's any bubbles. And again, post-operatively, enhanced recovery, etc., etc. That's fairly straightforward. But the real question is, what do you do when you find a leak? And again, the initial treatment is, I'm sure, the same. Nail by mouth, antibiotics. If you can drain it, do interventional radiology if you can. Trying to get the diagnosis is very important. Sometimes it's very clear cut, but a lot of times you need to do, we tend to do a scan. If you do a CT with oral contrast or rectal contrast, the specificity goes up to 97%. And again, sometimes, I have a very good relationship with my radiologist. If I have a question, they help me answer it usually. And treatment, again, doing washout, doing a stoma, taking out the anastomosis, because the problems with anastomotic leak is serious. It can lead to death, can lead to fistulas, and also lead to hernias. So we can do a bit of discussion about a patient. This was a 54-year-old in 2019, had a previous endometrial cancer, but since then has had this terrible as you can see, complex fistulas. So in 2025, this year, my gynecology colleagues did a very good big pelvic accentuation with an APR vulvectomy, but also an ileoconduit and an end colostomy. Now, I'm not sure you can see. So she, didn't really do very well. Day 10, had a scan. I'm not sure if this work. Yeah. So, so this is the thing about having oral contrast. So as you can see over there, so that's the pelvic collection essentially. But the report said like there was a bit of small bowel. It's very close to it. Just looks a bit thickened. So that was treated with some antibiotics, and we were hoping that it will just dry up. The next day, we found that through the perineal wound there was fecal material coming out. So that already answers the question. But we still did a scan. And you can see that the contrast is now in that cavity. So there is obviously a leak at the anastomosis of the small bowel to small bowel ileoconduit. So this is day 11. Give me a show. And she was relatively stable. She wasn't crashing. Blood pressure, etc. was fine. Show of hands. Who would do something now? Oh, no one. Who would, I suppose, call someone? I'm supposed to call everyone, okay. If you had a group of colorectal surgeons, we'll probably be split in half. Some of us would go in now, but another half would go like, why don't we wait? Because she's stable. And to be fair, we elected to wait. So we waited 3 months, and to be fair, because if you think about it, the leak, yes, was going to going to the pelvis, but because the perineal wound was open, everything was coming out. So she was stable. We gave her a TPN. She was nil by mouth, long-term antibiotics. She did stay in hospital for 3 months, but we did go back in. And 3 months, we found that the adhesions were more favorable, but we still had to take the anastomosis down. Then we gave her an ileostomy because she had an ileoconduit on the right side. I had to do the ileostomy on the left side next to the colostomy. Now, the next day, we saw this. Just a quick show of hands, who would do something now? Okay. What I'm trying to say is sometimes, you go back 3 months ago, same patient, it's trying to get the timing right, trying to get trying to get a plan. Obviously trying to leave someone with a black necrotic stoma day 1, it's not really going to get better. You just have to do something. So we went back in and refashioned it, etc., etc. But what happened is there was a lot of conversations, a lot of X-ray meetings, a lot of MDT, like X-ray MDTs, looking at scans with like multiple surgeons and multiple gynecologists saying like, do we do it now? Do we do it later? But the outcome was that, she went out of hospital. I don't think she wants a reversal now. So I think she's had enough surgery, to be fair. But yeah, so that's the end of my talk. Got 5 more minutes.
Thank you. Very wise to come from Leicester to Birmingham. If you've got a four-week child, I'll do it more often. Can I just ask you just to give us a little bit of extra information? About 5 years ago, there were some issues between some gynae-oncology surgeons and some colorectal surgeons. I won't say in which institution. And it resulted in a document which is on the website of a number of societies, including the British Gynecological Cancer Society, about the role of gynecological oncology surgeons operating in women with ovarian cancer. And there are obvious tensions, who wants to be taking the bowel obstruction to theatre at 2 a.m, who wants to be called in to someone else's leak, all those sort of things. And we came to an agreement as to what was appropriate, and that's now on the website. One of the things that we agreed that we would do is that we would ensure that we would participate in the NELA.
Yeah.
Would you mind just letting everyone know what the NELA is and what they have to do?
So NELA stands for, I think, National Emergency Laparotomy Audit. Okay. So I want to say NELA started about 2015, maybe slightly less, maybe slightly more. We wanted, as an audit, it was about trying to look at the outcomes of patients having emergency laparotomies, and obviously it's trying to improve outcomes. It's also about trying to get all the trying to stratify patients. Because obviously, the more patients we have, the more information we get. So, trying to stratify patients beforehand. So again, when we started, when NELA was first introduced, it was, say, like a 4-page audit form. But I think now it's a lot more complicated. But the outcomes are, 10 years down the line, we now have a NELA specific or emergency laparotomy specific, morbidity or mortality score, which we then tend to use, in conjunction with the anaesthetist to talk and counsel patients. And we have a better idea and understanding. We tend to have a NELA specific audit coordinator or collector, but to be fair, all he or she does is just emails the consultant and says, "Can you fill up the form?" I'm pretty sure that's all we get. I then forward it to the registrar who did the operation, obviously. But that's where, it's a very good audit, and it does make a difference. And I'm very much a big fan of having as much information, because it does, but a lot of what you were pointing out about what I suppose the tensions were, which, to be fair, I find a bit unfair, because in my view, if someone wants to do the operation, okay, do I know about ovarian cancers as much as you do? No. But if 56% of malignant small bowel obstruction is ovarian cancer, I'd be a fool not to ask you a question, go like, what should I do here? And, we would obviously appreciate if you can say, if we knew that, like, okay, it'd be worth doing something if it's a new presentation, if there was someone, if patients potentially able to either have primary debulking surgery or interval debulking surgery, and the outcome is improve, then yeah, it would be worth us trying to do something. But I can tell you from experience, a lot of times, and definitely a lot of my colleagues would just go like, nah, they got multiple points of obstruction, and sometimes we would call the gynecologist, but if you call the wrong gynecologist, they would also say the same thing. I don't want to be too pointy fingers, but you know what I mean. Like, if you ring, if I remember ringing as a registrar, I rang the gynae registrar, and she said, "Don't do anything." I was like, okay, it's one less work for me, but it's not right, and that's probably what this meeting is for, and having this sort of discussion is most useful.
And any other?
Sorry, one very simple question, because I get a lot of conflicting answers from surgeons. In cases where you envisage there might be bowel involvement, what do you do about bowel prep? Because I get so many different answers from surgeons. So I know you don't give full bowel prep for a lot of cases where you start with surgery, but we're talking about.
If you want to look at evidence, mechanical bowel prep and oral antibiotics for left-sided colonic resection is almost gold standard now. The mechanical bowel prep option is always there. So either you give them full bowel prep, so Plenview or Picolax or Moviprep, or you do an enema before surgery. Okay. The antibiotic bits came out in the Lancet last year, or maybe 2023, and that's slowly going down to units, because I think 2019 we talked about oral antibiotics, and it wasn't widely adapted. But now I think I point Moab 2 shows that we should give antibiotics for right-sided colonic resections. The jury there's no strong evidence to say that you need to give bowel prep. But to be fair, for the type of operations that would, it's unlikely that you'll need to do a right-sided resection. And if it's small bowel, you obviously don't need to do any bowel preparation.
This is a comment really rather than a question, and one of the reasons that this talk is in the meeting today and René's talk is really just to remind us, particularly in the setting with first presentation rather than a recurrence, high-grade ovarian cancer particularly is really chemosensitive, and actually these women who present late, they come in through A&E in relatively poor performance status, but actually they have deteriorated quite quickly, and up until the point of their admission they've had good performance status. If we can get chemo into these women really quickly, actually we can significantly prolong their life if not cure them. And I think it's the same in the malignant bowel obstruction group. If these women haven't already had chemotherapy, they're chemo naive, really if we can get to them and stop our colorectal colleagues or whoever writing them off, and try and get in on that discussion early, we can actually make a really big difference to these women. So for me, that's the take-home message. Thank you so much.
Thank you.
And I will,